Okay, thanks everybody for coming. And I think I may have confused everyone earlier, and now we're going to bring some clarity to this conversation with our panelists. And we're going to go through three presentations, and then we'll have some Q&A with the audience, and hopefully, with this smaller group, have a little bit more of a discussion. So we're going to, I think we had been scheduled for 15 minutes for Q&A, but I hope we can get a little bit more time for that as well. Just real quick, kind of a warning, if you called in sick, that camera may catch you if your boss sees this on video. So if you ask a question or something, it's kind of set to view, film the panelists. But if you ask a question, there's a chance you'll be on the camera. So I was asked to warn everybody about that. Okay, so thank you all for coming. We're going to talk about this kind of intersection of health and housing and community development, and we're going to start with, Renée is going to give us sort of a kind of an overview of how these kind of concepts play together, how some of our friends in the health world see these issues, and then we're going to get to something a little bit more practical. So we're going to have Shannon is going to talk to us a little bit about sort of how this happens operationally at a project and how you interact with sort of your health partners. And then Patrick's going to lead us through some discussions about how you pay for some of this and some of the funding schemes, particularly through Medicaid as a possible funding source. So with that, we'll start with Renée.
Great. Thank you, David. And it was... for those of you who were able to attend this morning, it was really a wonderful opening. A great opening. and we were told that, you would start raising some of the themes, so this would pick up on them. So it's really quite perfect together. Hi, everyone. I'm Renée Markus Hodin, and I am the Deputy Director of the Center for Consumer Engagement and Health Innovation at an organization called Community Catalyst. I'm first going to tell you a little bit about the organization and our work, because that'll help you sort of see, I think, why we work in this area. I think, I'm a little bit of an odd duck here. Most people are housers or work in, developing affordable housing, and I'm from the health advocacy side. So now you know why I'm here. Okay, so just a couple of words about Community Catalyst. So we are a national nonprofit healthcare advocacy organization based in Boston. So I had a nice ride yesterday. And we're working to organize and sustain a consumer voice, making sure that there are consumers and communities at the table wherever healthcare decisions are being made. And so sort of our theory of change is that we're pressing for reform, but we're also, there's this conviction that decisions are better when those who are affected by those policies are at the table. Okay, so just to give you a sense of scope, so we have a network of state and local partner organizations, not affiliates per se, but like the organization that Patrick represents, the Pennsylvania Health Access Network, and you'll hear more from him later. And we're in with partners in about 40 different states, and we provide support both in terms of technical assistance, but also funding that we get from national foundations. So we work on a wide variety of healthcare issues, everything from access, coverage, affordability, oral health, children's health, prescription drugs, and the area that I work in, which is the last one on this list, health system transformation, or how we make the system better for people who need it most. Tell you just a couple more things about the center. And like the theory of change for Community Catalyst, we believe that consumers and communities need to have a powerful voice and a role to play in transforming the way that care is delivered in the healthcare system, and to think about health more broadly, which is one of the reasons I'm here to talk to you today. And we focus particularly on vulnerable and historically underserved populations. So this could include older adults adults with frailties, people with complex disabilities, people with multiple chronic conditions, a lot of the people that you serve in the housing sector. Just a couple of words about how we work. From that strong foundation of empowering and educating consumers and community members, then we then seek to build partnerships, identify evidence-based practices and policies, and then work to achieve better health through care that centers around the needs, values, and the people being served. We work in sort of three areas of the sandbox, if you will. So we live at kind of the intersection of policy and research. So we support a network of state and local organizations that are building a constituency of literally thousands, and I include FAN in that as well. And we also provide training, consulting services on consumer and community engagement at a wide variety of in a wide variety of issues. All right, with all that, let's get to the substance of the topic today, health and housing partnerships. So I'm going to talk a little bit about, oh, look at, there's some interaction here that I didn't anticipate. That's okay, I'm just going to, there we go. Put it all up there. So I wanted to shift to talking about why there's currently so much interest in the intersection of health and housing. And my comments are based both on sort of the understanding that we've developed over decades in working on the healthcare system, but then also some research and assessment that we've been doing over the last few years with the Housing Partnership Network. Some of you might be familiar with them. They're based in Boston, but a membership organization of affordable housers and the like. And we've been working with them over the last couple of years to better understand the intersection between health and housing and the opportunities. And we're doing some work with some of their member organizations as well. So this was really meant as a little bit of level setting. I have a sense that people in the room may actually already know some of this, but for those of you who just need a reminder, a little bit about the health policy landscape. So we are in a shift right now, and have been for a while, from what's called fee-for-service, meaning the healthcare system, the providers get paid for everything that they do, every test, every procedure, every part of every procedure, and the more that you do, the more money you get. And we're now shifting in many, many ways to what's called value-based care, where the incentives and the disincentives are to talk about outcomes rather than the quantity of procedures and tests and so forth. So the idea for value-based healthcare, and it takes many shapes and forms, but the idea is to reduce costs and improve outcomes. And part of that is through things like reducing unnecessary hospital admissions and readmissions, as well as admissions to nursing homes. And as I said, those are sort of driven by financial incentives as well as disincentives. So on the one hand, an incentive would be that you get a bonus for meeting a certain number of outcome measures. A disincentive is if you have, X percentage more than you should of hospital readmissions within 30 days. People getting out of the hospital and then bouncing back within 30 days. And so these incentives mean that Medicaid programs and Patrick will be talking a little bit more about that. Hospitals and health plans are sort of thinking more holistically. They're thinking about innovative ways to look outside their walls, because they realize that once they discharge somebody, they're going to bounce right back in, as I said before, if they don't have the proper supports outside of the hospital. So again, care doesn't end at discharge, and they're going to be they're looking to partner with community-based organizations who have expertise that they don't. So a couple of examples. We see this across the country, but a couple of examples that we're seeing also: Medicare Advantage, which is the managed care approach to providing Medicare benefits to those who qualify. It's an increasing percentage of the market. I think we're at maybe a third of the market or so is now covered by this managed care approach, as opposed to the traditional kind of fee for service. There's now going to be, this is just from the last month, CMS, the Center for Medicare and Medicaid Services, has finalized rules around providing services and making it more flexible for these health plans, these Medicare Advantage health plans, to go beyond the traditional covered services and get into more of what we'll talk about in a sec, social determinants of health. And I wanted to just raise, for those of you who were in the last session, David talked a lot about, co-ownership. This is the kind of the co-ownership that the health system is now looking for, with the medical system being one of again, to use David's language, one of the buyers willing to pay for better health. Okay, so I mentioned the social determinants of health, again, a little on the level setting side, because I have a feeling most of this is a bit familiar. In the medical system, there's sort of increasing acknowledgement that there are many factors that impact people's health, patients' health, beyond the care that they get from their providers, their doctors, their nurse practitioners, et cetera. So in addition to what we inherit from our families and from our health behaviors like diet, exercise, and so forth, there are many factors. Sometimes they're called the social determinants of health. Sometimes they're called the social and economic determinants of health. And that these all have a major impact on our overall ability to manage our chronic conditions, et cetera. And so there's a whole bunch listed here from this on the slide from the Kaiser Family Foundation. But I have to say, for this crowd and in the conversation more broadly, chief among those social determinants is safe, affordable, and stable housing. And David talked about that quite a bit earlier, about the benefits of stable housing for children and other folks that you serve. One of the examples I think that you hear quite often is if someone who has diabetes doesn't have a refrigerator in which to store their insulin, they're not going to be able to manage their diabetes. So very concrete. And again, to allude to something David said earlier, you guys are the producers of health. And so, again, all of these things, including housing, produces better health. And that's of great interest to healthcare entities, plans, hospitals, Medicaid programs. So I mentioned before that we've done a lot of research with the Housing Partnership Network and kind of looking across the board, what kinds of collaborations, what kind of partnerships are currently existing and where that might lead us. And so increasingly we're seeing investments in the health sector, and the research showed that they sort of investments in the health, from the health sector into the housing sector. And the research that we did sort of showed that there's a real spectrum of partnerships or collaborations, and everything from programs that promote health and wellness, kind of like the falls prevention, chronic disease self-management programs, those things, service coordination, so paying for a resident service coordinator, those sorts of things, on-site clinical services being placed in housing, supportive housing, which we'll hear more from Shannon about, all the way to affordable housing investments, and then literally bricks and mortar. And so the spectrum represents, this arrow that you see going from left to right, represents sort of an increasing level of complexity in the partnership, an increase in the need for data about your residents and their needs, and then, of course, an increase in the amount of dollars that might be invested from the health sector into the housing sector. So I'm next going to provide just a few examples, and then we're going to hear some good concrete examples from my co-presenters. Okay, first example is from Vermont. So in 2013, the University of Vermont Medical Center conducted a community health needs assessment. Some of you might know that community health needs assessments are required every 5 years under the Affordable Care Act provisions so all tax-exempt hospitals have to do this. And 2018 was the most recent one, although a lot of them are still engaged in that process. So when in 2013, the UVM Medical Center did theirs, affordable housing was identified as a priority. They made it part of a priority of their community benefit programs. And community benefits are required, as some of you know, of all tax-exempt hospitals. So what they did, after they identified that as a priority for them, they acquired a vacant motel. They renovated it to become temporary housing for people who were discharged from the hospital and had no other place to go. They partnered with the Champlain Housing Trust, who owned and managed it, and they added in services like case management, and that came from other community-based organizations. So it was a real partnership. And this is some of the results that from their study of what they did from, I guess, the first 32 people who were enrolled. And they're talking about $1 million plus in savings for their health system. So this is a real benefit, and it could not happen without those partnerships. I'm going to skip this example because David talked about in Arizona, United's investment into housing, Chicanos por la Causa, and go to Maryland. So in Maryland, and some of you may be familiar with Bon Secours, it's a large Catholic health system. They were operating based on a social mission, and I think we heard that in some of the other examples that David provided earlier, dignity and so forth. And they saw themselves not only as an organization with a social mission, but also as an anchor institution in West Baltimore, a really tough part of Baltimore. They also saw that their patient volumes were decreasing, and their analysis was the neighborhood conditions, the blight, the crime, et cetera, were really keeping patients away and also potential new staff away. So they purchased land. They partnered with Enterprise to develop and finance the project. The city and the state also provided support. So it was, again, a real partnership among many players in the sector. And then importantly, and again, from our perspective of consumers being involved, they really involved the community, finding out what they wanted, what they needed, and how to develop that. So ultimately, 720 units of affordable housing were developed on those lots. 1,200 people who had not been housed were housed. And they converted 640 plus vacant lots into green space. So the kind of community development that David was talking about earlier. Okay, I'm going to add two other quick examples. I'm sure I'm running a little short on time. So one from Minnesota, and somebody asked a question about rural, and so this will resonate. Hopefully, the person's here. So this is the Mayo Clinic. They helped to create something called First Homes, which is a community land trust with a $7 million investment. But there were many partners. Again, you'll see a theme here. Many partners. Philanthropy was involved, the State Housing Finance Agency, the Greater Minnesota Housing Fund, and also the USDA, Rural Development. And in this case, they were able to put together 875 units of high-quality, affordable housing. But this fund also encouraged another $360 million in private investment in downtown Rochester, Minnesota. Last example is one that we were involved in very recently with Renée. They working in Wilmington, because I know they work in many other places, but this is in Wilmington, Delaware. There are 1,500 plus vacant properties across Wilmington, and that became the new mayor's priority. And so Renée, probably many of you know, CDFI, created the Wilmington Healthy Neighborhood Initiative. It included a revolving loan fund to help revitalize those neighborhoods and promote affordable home ownership. And also support a newly created land bank that was done very recently. So last year, we worked with this as part of our work with the Housing Partner Net, Housing Partnership Network. We introduced Senair because of other work that we're doing with Trinity Health, which is a large Catholic hospital system across the country, including having a hospital in Wilmington. We introduced the two, and I think that this goes to David's idea of connectors. We're not the only connectors, but this is kind of where we were seeing a valuable role here. Connecting Trinity, based on our work with them, with Senair. And Trinity saw immediately that this was consistent with its own community investing program, and they approved a $1 million loan very quickly to the revolving fund, and that helped to leverage additional investment into that fund. And now, though this is very recent, so this is a work in progress, there are already 20 homes targeted and that are in the kind of pre-development stage. So what does this all come to? I just wanted to pull out some of the things that were part of these examples and some of our research, and where the opportunities are for housing partners to, partner more with the health sector. So one is the community health needs assessments. As I said, they started redoing them in 2018. They're still going on, and you can help to shape the priorities that come out of that, but also pay attention to where it's going. I will bet housing is going to be identified in many, many of these. I know in Greater Boston, there's kind of a collaborative of hospitals that are working together. Housing is, they're in the process, but housing is no doubt going to be one of the priorities, and that helps boost your argument for partnering. Being at key tables, and these will vary by your location. This could be round tables on homelessness, which you may already be sitting at, but they could be in the health sector, like a working group on mental health that tend to include more of the health sector, but being at those tables is really helpful to meet the partners, be able to talk about what you bring to the table. Getting familiar with relevant health programs, Medicaid being one of the key ones, but also programs that come out of your mental health agency, your aging agency, and I know somebody here is from aging, Beth. And then monitoring bodies that have been created in the healthcare world and those processes. So, for instance, in Massachusetts, there's this Health Policy Commission that pays attention to health costs. That's an ongoing process. You learn much more about what the health system is thinking about. And where the opportunities are. And again, being in the same room with healthcare entities. All right. Lastly, just a few lessons about what successful collaboration requires. First is translation. I think the sectors completely speak different languages, and there are tools out there, jargon busters, if you will. And there's also, people like me who can help sort of, be a little bit of a translator. Understanding what the mutual interests are. So understanding where the health sector is coming from in terms of their obligations and value-based care. Understand, your own assets and how they relate to the same populations you're caring for and serving the same populations, people with complex health and social needs. And so you share, the same interests. Collecting data. I think, from my experience, housing organizations collect data in different ways at different levels. Some not at all. Some, in great depth. But getting more of a finger on the pulse of your residents and what their health and social needs are, that really helps to bring to the conversation with a healthcare entity. Dedicated staff. It takes time. It takes people. It's not something that can be just kind of a side project. It really takes somebody kind of going to those key tables, collecting the data, making the connections, and it takes a commitment from your leadership, quite frankly. Creating a narrative, telling a story of your organization and what you bring to the table. I would say, many of you have resident service coordinators at, having varying levels of responsibility at not necessarily at all of your properties. Resident service coordinators are gold. They are just gold, and bringing the value of having somebody who's got the finger on the pulse of residents is also incredibly valuable to health entities. Getting to know the right people, we talked about that in getting at the right tables. Seeking external support, you may not have the support or the resources internally to dedicate staff, but there are philanthropy dollars out there that might help you do this. So looking creatively at your philanthropy sources. And then finally, recognizing that it takes time. It doesn't happen overnight. Relationships have to be built. I think the United example was something like 5 years in the making before the investment in the actual housing happened. But they started with smaller projects together, and then they built trust, relationship, and understanding of each other's assets, and then were able to get to that point. So I'll stop there.
Renee, that was really great, and thank you so much for sort of making this really concrete. And I think the translation issue it's really critical. I remember being in one meeting, we were well into the process. We were talking about how you need to talk to CDC and get one of them on board, and the hospital said, why would I want to talk to the Centers for Disease Control about this? And so that happens a lot. So having people in the room who can translate is really important. And the fact that resident coordination, service coordination is gold is really a fantastic segue to Shannon to talk to us a little bit about that idea.
Yes, thank you very much. And I do appreciate that, because a lot of times supportive services where it's under-recognized, and we really... a lot of times I was saying supportive services is under-recognized in the industry of the importance and the difference that it really can make at the properties. So what I was asked to do is I'm going to talk a little bit about the partnerships at a higher level in the development process, and then also in the management side of things with the supportive services on site, and how we really are trying to address the health and housing. Again, I'm Shannon Mowery. I'm the Director of Supportive Services for Pennrose. Just to give you a little bit overview of who we are, we're a nationally acclaimed multifamily real estate developer and manager. We specialize in multifamily, mixed income, and home ownership developments. Our mission is that we're a committed team of exceptional professionals transforming communities by creating high-quality real estate developments and delivering outstanding value to our clients and partners, as I'm sure most of us are. A little bit about Pennrose's history. In the 1970s, we were involved with the Section 8 programs, primarily in Eastern PA. In the 1980s, that was when we actually developed our management company, and we had our first low-income housing tax credit property. And I believe that was with PHFA. In the 1990s, we continued to grow our platform, as well as the 2000s. And then most recently in 2017, we acquired a minority ownership in Hunt Industries, which has also helped our development side of things be able to have better partnerships nationally. And again, just to kind of show you how long we've been doing this and kind of our experience and what we've learned along the way. We have over 265 developments, over 17,200 units that we've developed over the years. And I think what I really want to point out is that we've had 100+ partners. We recognize that partnerships are extremely important in helping with the delivery of services to our residents, as well as the bricks and mortar. And a little bit more on the development services that we do provide. That we provide affordable, market rate, mixed income, mixed use, senior family, and student development projects. We're kind of, over the years, we've expanded and we do more and more of the different types of housing. And currently we're operating in 16 states. As far as the management company, we primarily manage the properties that come out of Pennrose, but Pennrose also develops in states where we're not the management agent. So we still have a compliance portion that we oversee with our developments in other states. And that's just a little geographic footprint. One thing that I just threw in here, Pennrose has now founded, or established a foundation, and it really shows our mission. And I wanted to put this up here because we're talking about health and housing, and the foundation is really another way that we could give back to the communities. As you see, one of our pillars is wellness initiatives for seniors and families. So we recognize that we could do so much in the management and development world, but through our foundation, we're hoping we can even further our mission and be able to reach not just our residents in our communities, but the larger communities that we work in and serve. Just an example of some of the things that so we're just kind of starting off, but one of the things that this year we're very proud of is that we're able to give scholarships to some of the children who live at our property to move on to higher education or trade schools. So we're hoping to further that as the years go on. So I wasn't sure who in the room would be very familiar with supportive services and what value it adds to the properties and how that all ties into health and housing. So I just kind of wanted to give you a brief overview, and I'm going to speak to how Pennrose does supportive services. We have a fully staffed supportive service department, which I oversee, and those individuals are on site working with the residents. They're building relationships, which we know is the most important piece of it, and they're also building those community relationships, those community partnerships. You know, sometimes they're big and they're obvious, like aging and adult services, but sometimes it's those little community partnerships that aren't as obvious, that take more time to find, you know, the local mission or local church that gives back to the residents and can really help them. So they're really key in a lot of this. Another way that we provide supportive services at our properties is through third-party providers. If we recognize that maybe, you know, we talk about homeless populations, we talk about supportive housing. If we recognize it's something that it's not our expertise, or that, you know, we really need to look for the experts in the community, then we'll reach out and ask another organization and we'll contract with supportive services. And lastly, we really feel that supportive services is the key to making all of this work. Whether it's through our on-site supportive services, whether it's through our third-party providers, but we have the approach that every single staff person is trained in supportive services, kind of the holistic approach, down to our maintenance staff. So everyone goes through annual training so they fully understand it and are really there to help the residents. And again, just, you know, I wasn't sure who would be in the audience, but when we talk about why we have supportive services in housing, you know, it really is because our goal is to have happier, healthier residents. The supportive services are there to link the residents to maybe those services that they aren't easily able to access, or, you know, breaking down the barriers so they can get the services they need. The other thing that we sometimes fail to realize with supportive services in housing is that, yes, if you see it's the right thing to do and it increases the quality of life for residents, which is the most important thing, but it also increases the property's bottom line. So whether we're talking about health and housing as far as seniors go or families, at the end of the day, you know, it's the right thing to do, but it's the right thing to do for our business operations too. I think on average in our industry, if through supportive services, if we can save one turnover or one vacancy, we're saving $5,182 to your bottom line of that property, which is a huge number. So, you know, we really look at it from the big picture, not just it's the right thing to do and what we do for the residents, but how it helps our property operations. One of the things that Jolene had asked me to speak about today was the tab 11 and the 62 plus preference. We know it's important. Obviously, if you guys are doing, you know, our PHFA tax credit applications. And just to give you a background, even though I'm the director of supportive services for the management company, I also work with all of our developers and our development team to help write the supportive service plans and execute and oversee them. Again, you know, we talk about the 62 plus health preference and how we can execute that, or what partnerships, how to make that happen. And it's important because of the points and because, you know, of the application, but I hope, you know, you're seeing that it's not just because of that it's important. It's because we have lots of things to solve for, like aging in place and helping our residents stay healthier, because there's no affordable assisted living, you know, and they can't we don't want them to have to transfer to nursing home, and all of the things that my other panelists have been talking about. And I believe, Jolene, did you hand out the? Yes. Okay, so everyone has that, so I'm not going to read it, but you'll see some of the partnerships that are on there for the tab 11 and the 62 health preferences. Some of the partnerships that I wanted to talk to you about briefly that we have worked on over the years. We'll talk about some of them in a little more detail, but this is just a list. We have West Turner Residences and St. Luke's Hospital that we partnered in Allentown, PA. Eastern Woods Development and our Blanchard Valley Health Systems. That's actually in Ohio. Kinder Park and Mercy Health. That's a property that our development team developed, but we don't manage. And then we're going to talk a little bit more about the North Hills Highlands and Kane Regional Center, which is an assisted living facility, St. Luke's Manor and an intergenerational school, Mary Taylor House and the Hickman, and then our overall partnership with Beata Home Healthcare and what that has brought to our properties. So the first one I want to talk about is West Turner Residences in Allentown, PA. It's a 61-unit property, 62 plus. And as you can see, we have partnered with St. Luke's Health Network. And on our main floor, there's 6,000 square feet that are committed to space for geriatric, physical therapy, and other senior focused medical functions. That doesn't really paint the big picture. I mean, it's great that we have the space right there on site, which we know, breaks down a lot of barriers for the residents to access those services. But I think what's really key is we have an on-site supportive service coordinator. We have the property built on the health campus. So the actual hospital is only a couple blocks away. And because of all of those kind of key factors to help people access services, we've really seen healthier residents or people who are managing maybe illnesses that they couldn't before. And I have later in the presentation that I'm going to share some resident impact stories, but since we have the slide up here, I just want to kind of hit home to you what it really means from a resident level. We have a resident who always lived in the city of Allentown. He was kind of one of those seniors who stayed on maybe relatives' couches, didn't really have stable housing. So when West Turner was built, he applied. He was able to abstain, he wasn't able to qualify for this quality, stable housing. And he has diabetes. And as we know, diabetes is something you have to constantly manage. And he was struggling. He was at the point where he was maybe having infections that were going to cause him to lose a limb. Really at that point of, wasn't sure how things were going to go with his health. But because he was able to have stable housing, because he was able to have the health services right there that he was able to access, because of the outreach programs that we were able to bring on site, he was building those relationships with nurses or the physical therapists that were doing the presentations. And his diabetes is completely manageable at the moment. And, without all that stuff, you have to wonder, where this gentleman may be today. So that's really one example that, bricks, mortar, and the services, why they're important in housing. Another one that we're going to talk about is the Blanchard Valley Health Systems. This property is built on the property of a continuing care retirement community. We have a couple of developments that we're talking about right now with the same model, because we know that independent housing works to a certain point, but then sometimes people do need to transition to a higher level of care, or maybe they have independent housing but they can use some of those services from a higher level of care, but not necessarily all of them. So these are models where we're really looking at being able to bring some of those services on site, or having the residents that live in these communities be able to easily access the services and programs in the continuum care retirement system, such as meal services, social activities. So what we're learning is all of those are important, not just when we think about health, we think about the physical stuff, but we also have to remember that includes the social health as well of our residents. Kinder Park is another property in Ridley Township, PA. It's 91 units, and we have partnered with Mercy Health, and there's 22,290 square feet of commercial space that will house the PACE Senior Care Facility. So if you're familiar with that, that will be a huge opportunity for our residents to access, their facilities and all the programs that come along with that. And then just some others that I don't have pretty pictures of, but I want to talk about briefly. North Hills Highlands and our Kane Regional Center partnership out in Western PA. That's one where we also partner with an assisted living, and we've seen great success where we're able to bring in meals on site. We're able to have our residents utilize their van services to access shopping, things that are still important, still make our residents feel like they have a purpose, make them be able to live independent or access some of those things that we take for granted. Another one that I added on the previous slide was St. Luke's Manor and our partnership with an intergenerational school. It's not as obvious, the health partnership with this one, but the idea is that the senior housing was built right next to a charter school with the whole idea that the school's programming and the housing is integrated so that the seniors would come on site, interact with the students, have programming daily with them. They might be able to do some volunteer work in the school and vice versa. The students come into the senior housing facility and provide some services as well. What's neat about St. Luke's Manor and our intergenerational school is that even the common space is kind of built with pathways and gardens that you could see, it's for kids for play, but at the same time there's benches for the seniors to sit on, and it's providing that space for both populations. And then lastly, what I really want to highlight is our partnership with Beata Home Healthcare. This is one that we're still fostering, and it's one of those partnerships where we both have to continually put effort into, but we have seen great success from our partnership with them. They provide a wellness navigation program, and I'm going to again give you a direct example of how their services have directly impacted a resident. We had a resident, which is, I'm sure if you work in housing, is very common. It was a senior resident who doesn't have a lot of family left. And so they didn't have that great support system, and they were starting to fall. Every time they fell, they would go into the hospital. We would learn after the fact, they're in the hospital. They'd come home, and it just seemed like more and more the falls were happening, and when they were going to rehab a lot longer. With working with Beata, one of the things we learned that the longer a resident stays in rehab, the less likely they're going to come back to their home to live independently. So to us, that's a big red flag for many reasons, because, we don't want, if it's something that we can help our residents prevent, of course we want to do that. But also, again, we're going back to that turnover rate. If we have an aging property, and this is something that's going to continuously happen, you're going to now have a property that's financially in trouble. So, we really got together and said, how can we maybe partner to address this? And through their wellness navigation program, if the residents agree to participate, Beata will follow that resident through the health system. So they'll go into the hospital, they'll meet with them, they'll talk to their teams, they'll help transition them to a rehab, but then the key part is that they help them come home when they need to come home, not necessarily when the dollars say they need to come home, which is that piece that was missing. Because if the dollars are paying for rehab, a lot of times they'll keep people in rehab, but they might not necessarily need to stay there. So through Beata being able to help people come home, what they are also able to do is make sure that when they came home with the right equipment. They were able to go into the apartments. They were able to assess any fall risk. Things that maybe us on site, we're not skilled to do, we're not trained to do, or we might not have the resources to do. So we've really been able to show through our partnership with Beata the value in that health piece and helping seniors age in place.
Great, thanks, Shannon. And one thing I want to highlight is Renée had the example of Vermont and the savings that was created from that being able to save $5,000 a turnover, like having that in your back pocket to sort of say, to explain what your value proposition is in terms of the value that you create. I've often said to housers that by far the more valuable than the buildings in your portfolio are the relationships you have with your tenants. And in the case of that one avoided amputation, that's $100,000 savings
Right.
to the system. So that's what you're talking. The magnitude is mind-boggling. I also wanted to highlight. I thought Shannon did a great job with talking about telling a story about some of these, focusing on a resident. And a friend of mine, Raphael Bostic, was Assistant Secretary of HUD in the Obama administration, and he basically said the one thing that was untouchable in his budget. He said that once the Republicans took over midway through the administration, that there was a lot of attacks on the HUD budget, but nobody touched the supportive housing budget because of the $1 Million Murray story that Malcolm Gladwell wrote in the New Yorker many years ago. Just because everyone just got it. It's like, yeah, it's expensive not to take care of people, right? Even, no matter what your political orientation is, everyone got that. So that's really helpful to have those stories. Appreciate that. And Shannon's not feeling well, and she powered through that. That was very impressive. So thank you very much for making it here. Patrick?
Sure. Either that or
yes.
that. Thank you. So good morning, everyone. My name is Patrick Keenan. I'm the Director of Consumer Protections and Policy for the Pennsylvania Health Access Network. We service folks across the state of Pennsylvania. We're in about 60 out of 67 counties. We run a statewide helpline that basically is kind of on the front lines of everyone's healthcare experiences. So we've seen tremendous change in the healthcare system, and our helpline is kind of the single point for both in private insurance and public insurance, whether it's Medicaid, CHIP, employer-sponsored coverage, the marketplace, and so on. Our interest in this topic of housing as health has really been around Medicaid and continuing the good work that you heard about at Pennrose, because I think a lot of the examples have focused around seniors because there's existing funding streams, but there's a broader population of individuals that are more eligible, that are also eligible for Medicaid now, and we're kind of missing that piece. To put into kind of context, when Pennsylvania passed Medicaid expansion or moved to a streamlined Medicaid expansion in 2015, we knew right then and there that there were over 1,500 individuals that were chronically homeless. The change that happened in the healthcare system was that previously these individuals might have short periods of eligibility for Medicaid that might be bouncing on and off of the system. It was really hard to stay connected to the program. But with Medicaid expansion and the simplification of the rules, the one commonality that now all of these individuals had was that they were all eligible for Medicaid, and those payers, the hospitals, the health systems that were seeing those individuals come into the door, had kind of a common thread that brought all of those individuals together, and that was Medicaid. But the issue that we know, and I think that what we've heard, quite clearly, is that the hospital can only do so much. They can kind of treat within their walls, but that's kind of why Renée and everyone else here has been kind of laying out this bigger case. The truest example for us was when we were talking to an individual who, we had enrolled in coverage, and they were so thankful. They came to us, shortly about 6 months after we had signed them up for coverage, and they said, thank you so much. I'm so excited. We were, asking them, how is it going with their doctors? Fine. We were actually in a federally qualified health center. And they said, and I'm so grateful I don't get those big bills for the ER and the hospital stays anymore. And I said, well, why are you going to the ER and the hospital? And they said, well, we know, I know that if, I don't take my diabetes medication and it's cold outside or it's too hot outside, I can, aggravate my symptoms. I can go into the hospital and I can get a roof over my head, right? And now I don't have to be, worrying about, people telling me that I owe $30,000 or $40,000. So that was the win for them. For the rest of us, we said, this is a complete missed opportunity. What we actually did is work with the Corporation for Supportive Housing Services to do two things. One was a crosswalk of Pennsylvania's existing Medicaid program to kind of analyze where the gaps were. And then the second was a business case to say, what would happen if we targeted those 1,500 people with supportive housing services, both pre-tenancy and tenancy sustaining services? So it takes a lot, as you all know, many of you that own properties or manage properties, folks coming from street homelessness within your four walls, there's some steps that need to be taken and some additional supports. That's a really critical transition period, right? So those pre-tenancy services are often forgotten about. It's kind of like, a given that someone's going to get into your walls, but it's not that easy, right? So the second thing is, we need those pre-tenancy services, the things that help people move into properties. But we also need the things that keep them stably housed, all of the things that have been articulated here. And around the same time, we also had guidance from CMS, the Centers for Medicaid and Medicare Services, that Medicaid was interested in paying for some of these services. Not all of the services. Medicaid itself is not going to pay for bricks and mortar. But when it comes to the services piece, I think many of you that have developed properties or managed properties know that services piece is the hardest thing to fund. You might have a little set aside in your trust, to kind of pay for some ongoing services. but it's not enough, or the partnerships that you have, your partners are really struggling with being able to provide those. What the business case showed us is that even after we paid for those benefits, the pre-tenancy and tenancy sustaining services, Medicaid would net a savings. The overall savings was about $3 million a year. The state share of that, what Pennsylvania would pick up, is about $1.47 million. Not too shabby. What does that mean? It means not only do we get people, off the streets, into housing, stably housed, and have a houser that has the resources and supports that they need through their partner, that's providing those supportive services to keep them in that housing and avoid that churn and that costly expense of having them leave or re-enter. But they're also, people are getting a benefit, right? So this is really a win-win situation across the board. I think that what we've, I'm going to go really quickly through these because I know that we want to get to individuals' questions, but I think we saw a couple of key gaps. So again, we were focusing on the non-elderly population that was eligible for Medicaid expansion. The last box on here is the biggest gap that we saw, is a lack of service coverage for individuals with substance use disorders. That's something that we need to change here in Pennsylvania, and it's actually something that Governor Wolf, under his leadership, has been really committed to changing. Some of you may have seen the governor make the announcement in September of last year that Pennsylvania was going to invest $15 million a year for 2 years from a SAMHSA grant, specifically on supportive housing services for folks with opioid use disorder, specifically on opioid because that was the federal funding stream. But I think what it talks about is the political landscape that we're in right now, is that this is, that's a relevant topic, and it's a place where we can make immediate impact and kind of show the results because of the attention that's being paid to that issue right now. So what have we done with all of this information? We know that some good things are happening, but we're far from being done. FAN is kind of in the middle space. We, with the Housing Alliance of Pennsylvania, which many of you may be familiar with, created the Housing is Health Coalition, which was really about having that first conversation between housing providers and healthcare providers. Because when Renée said they don't talk the same language, it took me a long time. When I think, many of you all may laugh, but when I hear continuum of care, I always think about hospital transitions to nursing homes and all of those things. And so for literally a year and a half, I was sitting in meetings hearing about COCs and continuum of care, not realizing that those were, the place that's, pulling together the state funds and the dollars around homelessness and outreach. So it really is a whole different ballgame. But what we realize is that we have to get on the same page, because I think what happens, the real danger here, so Pennsylvania is really interested in moving forward in some way with doing supportive housing services. It's already done it in community health choices. So if you're familiar with, the program that covers seniors and people with disabilities, there's a supportive services benefit for those getting long-term services and supports. It's not something that's being highlighted right now because CHC is a huge transition for the state, but the infrastructure is there and it's moving out. So if you're not already familiar, we don't have time to talk about it now, but if you're not already familiar with your community health choices MCOs, there's 3 of them statewide, 3 good partnerships to be working with: UPMC, Community Health Choices, PA Health and Wellnesses plan, as well as a Keystone First or AmeriHealth, depending on what area of the state you're in. But the reality is that our health choices, for those in that Medicaid expansion population, for those in the chronically homelessness, they haven't gone in that whole direction yet. And unless we get the housing providers together with the Medicaid providers, we're often likely to see the state make some decisions that may not, benefit everyone exactly like we want them to, right? So I think it's really important for housing providers right now to be vocal about how services that are provided in units are going to be, who should be providing them, how they're providing them, they're being very specific and vocal about what's very helpful. FAN brings, to that, the consumer's perspective. What do consumers want to see there as Pennsylvania thinks about making some of these choices? And ultimately it's about bringing those two forces together, about about the people that can provide the housing, the people with the health care, and the consumers that are actually affected by both of those systems, to make sure that Pennsylvania makes the right choices in that. So I want to close just really quickly, on that substance use disorder. This is one of the consumers that we've worked with, and she doesn't, for confidentiality's sake, we don't specifically put her issues with substance use disorder here, but the housing piece was often the missing piece in her recovery, right? So you're not able to bring together your family under one roof to maintain a job, like if you're constantly circling in between recovery and housing, and what you see at the end here is a family that, through supportive housing services and having the right kinds of supports in place, not only are you able to kind of break out through the cycle of addiction, but you're also able to keep that family together, which is an incentive to stay in long-term recovery and ultimately, contribute economically to the community to get back into the workforce and kind of make that. So, when we talk about that role that, and this is something that, when someone has nothing else but Medicaid, this is why Medicaid really needs to step into that space, because it's much easier for them to kind of do that. I think the question that we're all really left to kind of answer, and what I invite you all into, and with the Housing Alliance, into the Housing is Health Coalition, is how do we make those choices right now as Pennsylvania's thinking about that, and how do we kind of get the housing providers speaking up about what service delivery looks like, because we have, many consumers just like Sierra here that can kind of speak to their experiences, but we need to put that conversation with the housing providers side by side to make change at the state level. So.
Great, thanks, Patrick. You've got a lot of talent here, so that's pretty impressive. I want to ask the audience to start thinking some questions. I want you to think fast because we have 15 minutes, and I'm going to take four questions. I'm going to come out to you because it's being recorded and you won't be able to hear on the recording unless you use the microphone. So just raise your hand if you've got a question. So we'll start here. The rest of you start. I'm going to take 4, and then I'm going to sit back down.
Shannon, thanks for the presentation today. It sounds like you're doing really good work. We're tax credit developers, and we work in Pennsylvania. And it's, on the tax credit side, funding is so uncertain. And with these partnerships, it sounds like there's so much work into getting them together. How do you deal with the partners and the uncertainty when you're putting together a tax credit application?
And hold on for a second. We're going to take these questions in a clump.
I'm never going to remember.
And then I'll give you a chance to all
Uncertainty
respond
in tax
how
when you're doing
it shakes
tax.
out.
Uncertainty in partnerships when you're doing tax credits.
So in creating partnerships with healthcare institutions, one of the challenges that we're finding is when you get into the right room, which is not easy because of mergers and systems and everything else, what is the compelling case to make to whoever those decision makers are of why a hospital should entertain a partnership with a development organization?
Great, good. Third question here.
And I'm curious, the partnership with St. Luke's, what did that look like? Was it MOU, letter of support, or did they put money on the table?
Lots of partnership questions today. Okay.
Having met with the MCOs, it's not evident that they're prepared to put real resources, real money on the table in order to engage in these partnerships. It seems that they're mostly interested in saving money by moving people out of nursing care into other housing sites because their monthly expenditure, moves from $4,000 a month to $2,000. So far, it's been a little bewildering and uncertain as to exactly what the MCOs bring to the table. Just with that, it doesn't appear that the state agreement that they're in compels them to do anything. So any enlightenment you have about that would be appreciated.
Thanks. And I want to take one last question. So anybody want to get one last question in before we tackle? And you guys start getting ready to answer and figure out who's going to go first. Is that okay? All right, we're good? All right. All right, panelists, who wants to go first?
I'll try to remember the first question. I believe your question was about the uncertainty of partnerships.
the uncertainty of funding and how to sort of get somebody on the hook when you don't even know if you have a project.
Right. And I have some of my development team in the room, so guys, feel free to join in and answer that question. And they probably can answer from the partnership side a little bit more. But, I think, just say it again, the uncertainty of the partnership as far as...
Well, yeah, so how do you deal with the difficulty of finding a partner and kind of getting them on the hook when you don't even know if you have a project to work
Right.
on because your funding is so uncertain?
I think from the very beginning, it's finding the partnerships and speaking the same language, taking to the table the benefits to both sides of things. And, you have to have the honest conversation to say, if we get funded in 2 years, this is what it's going to look like. But understanding that without their buy-in and without their input or their partnership, we can't make this happen. So it's really approaching it from, being able to speak to them in the language of how is this going to better the community? How is it going to help everyone involved? And having them be a part of it from the beginning and letting them have input in that partnership as well. I think that's important too. I don't know, Brian or Jacob, do you guys have anything you want to add to that since you are very involved in that aspect of it?
Well, he asked specifically about the resources, or somebody asked specifically about it. In the case of two of the examples that Shannon mentioned, the Allentown Sacred Heart project and also Kinder Park in Ridley, there's the actual financial contribution is a commitment to lease space, which then could be bankable to help with the capital stack for the whole project.
And as far as the services side, just to answer another question that was asked, as far as the partnership with the outreach programming and other on-site services that the hospital is agreeing to bring on-site, or the resources or barriers to break down, that was in the very early stages. That was just done through an MOU. And once we did win the tax credits and we went into development, then we just had an updated MOU, knowing that both parties in good faith will always work together.
Renee or Patrick, do you want to tackle one of those questions?
Do the hospital.
Sorry.
Do you want to do the hospital?
Yeah, I'll do the hospital and you do the MCO
MCO,
one?
yep.
Okay, great. So the question I think was, once you're in the room with hospitals, how do you make the compelling case? And I'd go back to something that I talked about a lot, which was around data. You can also, by the way, they can look at sort of you compare your catchment areas, make sure that they understand that the people that in your area are the people that are being served by their hospital. So that's helpful. I didn't mention this before, but there are some real interesting resources out there. One is Opportunity 360, I believe, that you can put in your zip code, your it's not even just zip code, it's beyond, I think it's even tighter than that. Census tract, thank you. And so that you can really show how the data that you have about your residents matches up with the data about your census tract, which matches their catchment area. Again, when it comes to tax-exempt hospitals, they have an obligation to provide community benefits. It's not the be-all, end-all. It's not going to provide you with, bricks and mortar necessarily, but there are ways to look at that, at the community benefit obligations.
So this is the question about the MCOs. I mean, I think specifically was referencing community health choices and the 3 statewide MCOs. And this is a great example of how the housing world and the Medicaid world are 2 very different places. So we've been having this conversation about community health choices for about 20 years now in Pennsylvania. It went live in the Southwest in 2018. It went live in the Southeast in 2019 and is going to the T in 2020. So it's a 3-year rollout period. We are not all the way across the state yet, and those MCOs are literally kind of just getting their feet wet, which is a bit anticlimactic for the housing world because it's been billed as, hey, this is something that's coming and everyone should get ready. And what, those MCOs are not actually moving into the housing space for probably another, each MCO will make their own decisions, but probably another 2 or 3 years. But I think The important part for folks to know is that pre-tenancy and tenancy sustaining services are defined in the Community Health Choices waiver. There's a huge incentive, as the questioner already mentioned, to get people out of skilled nursing and into community-based care. And so the question is, knowing that this elderly population and disabled population is only going to grow as Pennsylvania ages fairly rapidly, it's about making those partnerships now, because it's not passing the buck for the MCOs, but they're really kind of taking on a whole host of functions that previously hadn't been defined. And housing is, a priority in the CHC contract, but it's, as far as the enforcement side, it's something that they have to do. But, the state is also looking at, we want person-centered planning down, we want the long-term service delivery, we need to get all the medical stuff in place before we move over there. So it's a really good time to be having those conversations and thinking about how your housing, supports or bricks and mortar, can partner. It's a great time to have those preliminary conversations, but don't be kind of put off if the MCOs aren't, immediately kind of jumping into this water.
I'm going to put another plug for data. This is a good time to collect data on how many residents that you serve are part of the community health choices or eligible to be part of the community health choices if you're in the T.
Okay, it's about 11:22, and we've got about 8 minutes left. I've got a question for the panelists, and one of them is about this distinction between so there are those that are high utilizers of the medical care system that's a lot of what our conversations are about, and it really is about the substance abuse person struggling with substance abuse, or the homeless person, or the senior who's at risk of diabetes, et cetera. That's a super important conversation, but it's a very small percentage of the population. They drive a lot of dollars, but it's a small percent. The big fish is the rising risk, the person who's going to become homeless, the person who's going to become diabetic, that's pre-diabetic. So my question to the panelists is, have you thought through, or do you have strategies to get at the rising risk sort of population in the work that you're doing?
We'll talk about the state first. So I just want to say, because I'm coming from a Medicaid space, another area of work that we're engaged in is that the state, with all of its Medicaid managed care organizations, not just Community Health Choices, but the Health Choices program, is moving towards starting to screen and assess for the social determinants of health. Some MCOs have already been in there, some providers have already been in there, but what the state is trying to do is start to bring them all together into the same space to really assess exactly what that risk is. And the state is also in the process of procuring a tool that's going to start connecting some of that rising risk. So not everyone needs supportive services. People do need solid, direct and actionable referrals to services that can meet their needs. And the Secretary of Human Services has said this is what the department's going to do once that assessment is in place. So it's already there, and I think that's going to be another opportunity for folks that have just general housing to start partnering with the MCOs or providers or the state directly, to kind of get into that referral network for folks that aren't those high utilizers.
That's great. Renée or Shannon?
Yeah, I was going to mention the risk assessments as well. Increasingly those assessments include, go way beyond and should go way beyond medical needs. There's no question that the high utilizers or high need, high cost populations are of greatest interest right now to the health players in the health sector. But I think you offered some great examples earlier when you talked about United and you talked about Kaiser. Increasingly, the health sector players are really seeing themselves as anchors, anchor institutions, as contributors to community development. We talked about the Senair and the Wilmington side. So I think that we're seeing a lot more investment in the in community and economic development side. I think I predict we're going to see a lot more insurance companies who are sitting on a lot of reserves, quite frankly, seeing it as an opportunity, hopefully as an opportunity to go beyond, just their members and think more broadly about the community.
And I kind of speak from the perspective of what are we doing on site currently for the residents who are in our existing housing. And we're always, of course, with supportive services trying to be proactive. But some of the things that we're looking to do is we got certified in mental health first aid, recognizing that that's a huge area of who lives in our properties, and some of, trying to keep those drain dollars out of the medical system if it's something that we could kind of address at the housing level. So that's one thing we're doing to be proactive. We're always looking to, there's ongoing conversations that some of us are having with some of those choice, and I always say it wrong, I said the choice health organizations. Health choices, I'm sorry. The health choices organizations, talking about really how can we partner better? Because, and we're kind of sometimes hitting roadblocks, but I think eventually the conversation will expand. But from the housing perspective, we're always looking to how we can better partner to be more proactive.
It's really interesting that a friend of mine is a venture capitalist in Silicon Valley, and she does a lot of providing mental health care for big employers that need that, and she's got a lot of data, and like a lot of Silicon Valley people, the data is what really drives her. And what she's looked at, because we know that things like substance abuse or need for mental health services have preconditions and issues of moments of extreme shame or despair. That's really sort of the precursor to sort of these mental health issues. And we know that has precursors, and she's been running the data with hundreds of thousands of people. And I was asking her, I said, well, what's the predictor? And she's like, you will never guess, And my husband kept on asking, is it A1C levels? Is it allostatic load? Is it telomere length? Is it he's going through all of these different scientific things. She's like, no, it's when someone who regularly goes to the dentist, skips an appointment and doesn't reschedule, then I know to send assistance. So I think as we get better at this, as we get better at understanding how people work and how these interventions might be more successful, the data will drive us, I think, to interventions that are much smarter and much better and will help a lot of people and save a lot of money. I think that's one of the themes we saw on this. We have time for 1 minute each for you guys to have one closing comment. We're going to go down the list. Patrick, you go first.
This is just my thing is there's a broad movement of consumers, that are supported by FAN and kind of getting their voices, to state officials. And I think the most powerful thing, because I think by and large the medical community is on board. I think the absent piece, because I think it's been so confusing for many folks, is the housing piece. Like how do the housing providers engage in this kind of rarefied Medicaid space that seems so different? And so I would just really encourage, to kind of the points we heard earlier, find your way into that conversation, find groups like FAN and the Housing Alliance that are working on this and figure out ways to partner, because that's the voice that it would really be helpful to have alongside these consumers and state officials that are really committed to this change.
Thanks, Patrick. Renee, 60 seconds.
Maybe even less. So I guess I wanted to just lift up something that Patrick said about not getting discouraged about how long, and just reiterate it takes time. It really does. The will is there, the dollars and the incentives are there. Being in the right place, meeting the right people, and no doubt partnering with consumers and other community members that don't necessarily have a financial stake in the relationship is a really smart way of doing things, and stories.
Thanks, Renee. Shannon, you get the last word.
I just want to encourage people. We talked about some great collaborations that Pennrose does, and they're not always easy, and I recognize that. So it really is just, taking the time to build the relationships, to know the communities you want to develop in or build in, and, really using the local resources and the people to make those things happen, and just to encourage everyone to continue the conversations, because there's lots of resources and services out there, and we need to find a way to bring them on site to housing, because that is where we're going to make the biggest impact. And we need to be able to find ways to really improve our services that we're delivering on site.
Fantastic. Please join me in thanking the panel, and thank you all for your attention.